Well, hello there to all my friends and good evening. Welcome to Fertility with Fink and Friends, the place that you are supposed to be every Tuesday evening at 5 o'clock p.m. Central Time, which means 4 o'clock in the mountains, 3 o'clock on the West Coast, and 6 on the East. Live from Pensacola, Florida. My name is Dr. Randy Fink, and I'm a fertility gynecologist here at New Life Fertility in Pensacola, with offices also in Mobile, Alabama, and in Panama City. I also work with the fine folks at the Missouri Center for Reproductive Medicine in St. Louis and in Tulsa, Oklahoma. And it is great to see everybody here tonight. How's it going, everybody? Well, you know what? We are in a tropical storm warning here on the Gulf Coast tonight. But interestingly enough, well, and so it's raining outside right now. But earlier it was, it was sunny for part of the day, and now I think it is fortunately going to be mostly a non-event for us here in Pensacola. The storm system seems to be a little bit off the coast. It's meandering its way westward. It's going to, when it impacts, it'll be probably around Louisiana, Texas. So it is not a nice day at the beach here in Pensacola, and it is a wonderful place to go to the beach. So not a good beach day, but aside from that, I think fortunately we haven't had so much wind, and despite a little bit of rain, don't have too much going on out there. How's it going for you? It's so nice to see everybody. I was not with you last week. Had something come up kind of at the last minute and wasn't able to make it. So I apologize to all of those of you who were looking for me and didn't find me, but I am so happy to be back. So let's see who we have. We have Jordan McKinnon, it looks like. Hi, Heather K. Good to see you. Dee Meyer, hello, and thank you so much for being here. This is New Life Fertility's Instagram here. We've got Facebook, YouTube, LinkedIn for MCRM, for New Life Fertility, for the First Fertility Network, all right here. And here is my personal Instagram, and that's Randy Fink MD. Please feel free to follow me along. Try to put out some content for you to keep things entertaining. Hello, Sheila and Lauren. Good to see you. Indepino Journey, thank you for being number one on my list tonight. We've got Midgie here. It's good to see you. Lelix, hello, and Rosa, as always, thank you for being here tonight. And KN Davidson, how are you? We've got a few people over on the Facebook side, but it doesn't tell me who you are, so feel free to throw your name out there so that I can greet you personally. I hope you had a very nice weekend. I was with the fine folks up there at MCRM doing some retrievals from Wednesday night through Sunday. I came back home here, and the sad thing for me is that I had to miss the Blue Angels Air Show that was out on the beach at Pensacola, which is one of my favoriteest things to do. But we're not here to talk about the things that I like to do. We're here to talk about what's on your mind tonight. And that's the things about fertility, the things about making a family, getting pregnant, women's health, all that stuff that worries you. That's what we're here to talk about. So if you have questions for me, this is the time to ask them because I am here for you. One of the questions I got here is that, this comes from S. Charles, and S. Charles says, can I have endometriosis? If it's not in my ovary? So the answer to that is yes. So endometriosis, as you may know, is the process where the lining of the uterus that normally sloughs off when you have a period, instead of coming out of your body, works its way up north, works its way inside, and implants within the pelvis. This can do a bunch of different things to you. This can cause a pain syndrome. This can distort your anatomy. This can affect your ovarian reserve. It can create cysts in the ovaries, and that's what's called an endometrioma, also known as a chocolate cyst. And they call it a chocolate cyst because if you were to cut into that cyst, then you find that it literally looks like liquid chocolate, actually. The classic presentation of endometriosis is as a pain syndrome, but really by far the most common presentation of endometriosis is silent endometriosis. That is, people have it and they don't even know that they have it. So can you have it and not find it in your ovaries? So as I mentioned, some people will have a collection of that endometriosis fluid that's in the ovary, and we can see that usually very clearly by ultrasound. However, endometriosis in other places, when it's scattered throughout your pelvis, typically does not have anything that we can otherwise see. You really can't see it by imaging, so you can have all the ultrasounds in the world and it will likely not show it. You can have MRIs, and most of the time that doesn't pick it up either. Really, to diagnose that kind of endometriosis, you need surgery. You need a laparoscopy, where we literally put a camera in through your belly button and take a look on the inside, put eyes on that endometriosis. That's one way to diagnose it. We now have another way, a non-invasive way to diagnose typically silent endometriosis, and that's through a test that is a form of an endometrial biopsy. And that endometrial biopsy is a little straw that goes through the cervix and sucks out a little piece of the tissue from the uterine lining, the endometrium, and we can test that for a marker that's known as BCL6. BCL6 is a marker in the endometrium that tells us that with the presence of most commonly endometriosis, that it is going to have an impact on your ability to implant an embryo. And that's really when it becomes most important to us, because in many cases we're looking for this silent endometriosis in the face of someone who has had multiple embryo transfers, for instance, that should have stuck but didn't, and we only come to find that endometriosis may have been preventing that embryo from sticking. So yes, you can definitely have endometriosis even if you don't see it in the ovaries. In fact, I would venture to say most of the time you don't actually see it in the ovaries. A very special shout out to my friend, Dr. Rabia. Good evening, my friend. It is an honor to have you here. I truly do appreciate it. And hello to Lexi. And we've got Aaron has joined us. Hi, Aaron, who is in Dallas tonight, along with E. Winnick, who is probably not in Dallas. I said Aaron is there with E. Winnick, and I didn't mean that they're together, you know. But I hope you're enjoying your trip out there, Miss Aaron. Let's see, Kelly Lee is here with us over on the Facebook side. And again, if you have questions for me, throw them my way, and let's talk about what is important to you. I got another question from Miss Alice. Miss Alice asked, I am planning to freeze my eggs. I am 32. How many eggs should I freeze? And that is a great question. So egg freezing is really kind of like buying a fertility insurance policy is basically what it is. And this is how I explain it. If you've ever known someone who purchases disability insurance, right? Let's say you're working, you get disability insurance, and you work your entire career, you never become disabled, you never have to use your disability insurance. Well, your conclusion at that point is that however much money you spent on your disability insurance was too much, right? Because you never used it. It didn't turn out to do anything for you except it protected you, but you never used it. Whereas if you end up needing to use your disability insurance, then however much you bought was not nearly enough because you're cashing in on that policy and you just wish that you had more. So you're kind of hedging a bet there, you know? You're hoping that you never have to use it, but that if you do, that you'll have enough. The same thing really holds true for freezing your eggs. The goal with egg freezing is for you to get your eggs at a time when you may be a little younger, so the egg quality will be higher, so that if later on in life you decide that you'd like to have a baby, you can still very much do it the normal way if you'd like. But if not, then at least you have the option of having those eggs, and you can fertilize those eggs, and they're basically stopped in time from a DNA standpoint at whatever age you were when you got those eggs. So that's the benefit of egg freezing. How many should you get? Well, ultimately, it really depends. It depends on your goals. You want to have enough, but not too many, because doing multiple cycles may be more than what you actually need. There is a tool that I use that you can look up online through a site that's called MD Calc. So if you will Google MD Calc egg freezing tool, MD Calc egg freezing, or maybe it's egg freezing calculator, just do MD Calc egg freezing. You will pull up the site that basically lets you put in your age, lets you put in the number of eggs, either that you retrieved if you've already done it, or that you might be expecting based upon our estimations, and it will calculate for you the percentage likelihood that you will end up with one live birth as a result of those eggs, 2 live births as a result of those eggs, like 2 kids, or even 3 kids, 3 live births as a result of that number of eggs. It will give you the percentage. And so ultimately, how many eggs do you need becomes a question of how comfortable you are with any given percentage. So let's say that number is going to be, it gives you, an 88% probability of a live birth. I would say that number is pretty good. That number is probably better than average. And if that's the case, then maybe that's how many eggs that you need. But let's say that you do that same one cycle, and instead of, getting X number of eggs that gives you 88%, however many eggs you get, maybe gives you a 25%. Well, I would say a 25% probability of being able to get a baby from those eggs is probably not enough to make doing that worthwhile, would be my opinion. Now, of course, everybody's different. They're your eggs, but I kind of feel like if you're doing it, you probably want to at least have a 1 in 2 chance, or 50% probability, that those eggs will get you a baby. And so that's kind of how I look at it. It is really, how much fertility insurance do you need to buy? And the answer is, well, whatever you're ultimately going to be comfortable with. We can help you kind of work through some of those questions and some of those issues. And that's sort of what we're here for. That's really what we do. A very special shout out to Sammy this evening, who actually joined my podcast, my old friend Sam. Hello, Sam. It's nice to see you. And also the wonderful and talented Angelina Foxy up there in the great state of Minnesota. Thank you for being here as well. You are the bomb. The two of you are the bomb. Actually, everybody's the bomb tonight, because you are in the right place. Thank you for being here. Hi, Nessa and Sarah and Shalom Elizabeth and Lexi. We got all kinds of good friends here tonight. Ask me your questions, because I am here for you. Well, let's see what else we got going on around these parts. I got another question here, and this is one that has been asked before, and this comes from Bob Jean. It looks like Bob Jean. And Bob Jean, I guess that's like Bobby Jean. Bob Jean asks, does my husband have to do a semen analysis in order to be treated? Well, here's the thing about that. So when we're doing an evaluation about fertility, 40 to 50% of the time, if you're having a difficult time getting pregnant, the issue is The issue is actually the male. So we very strongly encourage that the male be tested so that we can see whether there are issues associated with sperm. It's really a very important part of things. Now, in some places, let's just say that you're a female and you don't ovulate, you don't get regular periods, but you want to be pregnant and you go see your OBGYN. The OBGYN may give you some medication to try to help you to ovulate so that you can do timed intercourse at home in order to try to help to get a sperm together with an egg. And that's generally fine. And a lot of times this will be done before a semen analysis is done. So it is not out of the question that you can do a few basic cycles of ovulation induction if you don't ovulate on your own without having a semen analysis done, because then maybe you're just sort of kind of returning your own probabilities to, closer to other people who do ovulate on a monthly basis. When you come to see the fertility specialist, we will always want to see a semen analysis because there are some nuances of that can make a difference in how sperm is reaching egg. And so generally we do want to see that. And so then, the question that some have, including Bob Jean, is, well, what if I am going right to IVF? Well, even if you're going to IVF, we still really need to know that there are sperm there. Because in the absence of sperm, what you're doing is just egg freezing, right? You're just making eggs, and then we have nothing to fertilize them. We don't want to get caught surprised learning that there are no sperm. And that does happen sometimes. We can have a situation, for instance, where a male has done a semen analysis and it's normal. And then for whatever reason, or maybe it's low, or maybe it's, whatever it is. And then for whatever reason, at the time of IVF, when he provides his sperm for collection for us to use for the IVF process, it turns out there's no sperm there. What do we do then? Well, we still, you've gone through a stimulation. We still have the eggs. So we'll just get the eggs and we'll freeze the eggs. And those eggs will be stopped in time. And then you can go along and sort of sort out what's the issue as it pertains to sperm and deal with getting sperm later. So once we have figured out the sperm problem and you have some sperm, then all you have to do is thaw the eggs and fertilize them. And that's kind of the way that whole thing goes. So let's see what else. I'm adjusting my lighting here just to make sure I look as beautiful as possible. Zenny has joined here as well, and Nessa is asking, will you be in St. Louis the first week of August? I will be in St. Louis for MCRM's retrieval week, which I believe is the week, or I'll be there for the weekend, the Thursday, Friday, Saturday, and part of Sunday. I believe that's the week of August the 12th. I will be there. So that's the second week, the second weekend, I think it is, in August. And I hope I will see you there, Nessa. That would be so cool. So cool. And Rosa is saying, gearing up for the second transfer. Very excited. I have endometriosis. After weaning, should I wait a period to return and then go on Orilissa, or just go straight to Orilissa after weaning? So I do know that Rosa has had some issues with endometriosis. Rosa, and speaking of, we were talking about this before, Rosa used to have and may still have an endometrioma in the ovary, and that's a collection of that endometriosis fluid. And the question is, well, after breastfeeding, getting ready to go to the next transfer, typically what you do when we know that you have endometriosis, what we want to do is that we want to suppress that endometriosis. We want to turn off that signal, the hormonal signal that's sort of supplying endometriosis, so that it will unlock your uterus's ability to accept the embryo. It has to do with implantation. We think that what that endometriosis actually does is that it blocks your progesterone. And if you're blocking the progesterone, it's the most important hormone that your body needs in order to get pregnant and to stay pregnant. So we're talking about suppression. Orilissa is one such medication that can be used for hormonal suppression to turn down the volume knob on the endometriosis. If you're breastfeeding and you have weaned, then you can go directly to Orilissa if you'd like. So the problem is, what you don't want to do is still be breastfeeding when you're on Orilissa, because medication can and will transfer into breast milk, but also the Orilissa is likely to suppress your ability to make milk. Now, what we know about hormonal suppression for endometriosis is that the highest odds for successful embryo transfer happen in the cycle just after doing that suppression. So I wouldn't want you, Rosa, to start to do the suppression until you know that you are ready 2 months later to go into your transfer cycle. So if you're not ready to have the baby at that point, don't start the Orilissa, right? Because once you start that Orilissa, the clock starts ticking. And that's kind of the way I would think about that. You want to make sure that you really maximize your suppression there, and that is to go directly from your suppression into a medicated cycle for your embryo transfer. And that's kind of how I would do it. So there is no advantage necessarily to waiting. It really has to do with when you feel like you're ready. Are you ready to be pregnant, at that point? And that's really the question I think you have to ask. But I am so happy, Rosa, that we are able to have that conversation, because you did that embryo transfer. That worked, and you are holding a baby right now, despite everything that told you it wasn't going to work. Because guess what? It did. And you, my friend, are a perfect example of why having hope is one of the most important tools you can have. What is this hope business? Hope is the desire to get things the way you want them. And I do think that there is something to be said for that. There have actually been studies that show that hope does make a difference. But I see every day folks who feel like they are out of hope, that they have spent all the hope that they could possibly have, and they're just done with it. But yet they're going through treatment. And yet they just have no belief that it's actually going to work. That hurts. You know what? It hurts you. I think it affects your cortisol levels. That's our body's stress hormone. I think that's something what we put out into the universe is what we get back here to ourselves. And so the ability to have hope, positive vibes, I think, end up with positive betas. Negative vibes, negative betas. Now, obviously, that's not always true, but I really do think it makes a difference. And so to the extent that you can, hold on to that hope. Just like Rosa did, because now Rosa has a baby in her arms, despite the fact that, Rosa, you're 44 now, and I think you had like a 5 or 6 centimeter endometrioma in your ovary. You made those embryos a little bit later, but yet you did this. You pulled it off, and the universe has smiled at you. And I hope it will do it again. All of our fingers are crossed, and our love is coming your way. And it's my pleasure. She says, thank you, grateful forever. Let's see, Nessa says, so will you be, so you won't be doing transfers for August at MCRM? No, I will not. I'm doing retrievals in August at MCRM. Sometimes I'll also do transfers in Tulsa, but not this time. I will be in St. Louis. But you could stop by anyway, because she asked, does having a tilted uterus make it harder for an embryo transfer to stick? And the answer is nope, sure doesn't. So here's the thing about that tilted uterus. Just like some people are right-handed, some people are left-handed. Some uteruses sit forward, some uteruses are in the mid position, some uteruses sit backward. Now, what does that mean in terms of what you might experience? Well, if your uterus sits backwards, and that's called a retroverted uterus, you may experience more cramps in your lower back. You may experience, like when you get crampy, you may experience some more kind of like rectal pressure. If your uterus sits way forward to the front, then it sits literally right underneath your bladder. And when your bladder gets full, you may feel that in your uterus. Or when your uterus gets crampy, you may feel that in your bladder. So that's kind of the difference. But sperm can swim this way, or that way. An embryo can go this way, or that way. And it does not matter. Now, the only caveat to that is that once you are pregnant, if the uterus sits very far to the back, sometimes as the uterus starts to grow, it can start to kind of pinch on the cervix, and it can cause some issues really with your bladder. But temporary, and these things are always kind of solvable. So the good news is whether you're right-handed or left-handed, Nessa, whether that embryo, whether that uterus sits forward or backwards, you still have the ability to keep that baby inside and for that embryo to stick 100%. Hi to Lisa and Nina Buena. Good evening to you. Krista is here also, and Krista asks, if you have no history of polyps, do you have to do a saline sonogram, and is Omni a good medicine to prime with? So here's the thing. If you're doing IVF, right, you are investing a lot of money and a lot of heart, a lot of financial capital and emotional capital into making an embryo and getting that embryo to stick. So you want to do everything that you can to make sure that that environment for the embryo is as hospitable and beautiful as the embryo itself. So it is a standard of care that we want to take some kind of peek inside the uterine cavity. So that is either a hysteroscopy where we look, or a saline sonogram where we put a little fluid inside while doing an ultrasound, also called a fluid ultrasound, because we really want to know for sure that there is not some scar tissue, that there's not a polyp, that there's not a growth, that there's not a band of muscle, that there's not a septum, that there's not something there in the uterus that may prevent your beautiful, perfect embryo from implanting. So while it's a little bit of a hassle to have to do it, in my opinion, it is well worth it. And most places will say, look, we're not going to transfer an embryo into you because, you know, this is a life, really. And so we want to know for sure that that environment is perfect for your embryo. So that's kind of why we would want to do it. Hey, folks, it's 1:30, which means it's time for the 5:30 Fuzzies with Fink. The Fuzzies with Fink. If I had music, I would play it, you know, but I don't. I'm not a radio DJ, you know. The Fuzzies with Fink is that time that that we can all kind of get together here and just take a moment to give some thought out to all those people out there tonight who feel alone, to all those people who feel frightened, to all those people who just are anxious, who are depressed about things that have happened in their lives, who are anxious about what might happen tomorrow. As it pertains to fertility, it's a really uncomfortable journey to be on because we don't know what this journey is going to give to us or when it's going to give to us. It's hard to hold out that hope that we talked about before. I am a big believer that almost everybody who watches my program here would give the shirt off their back to help someone else who is in a similar situation to them, who is in need, and who is frightened, and who feels alone, and who's scared. This is the time when we can stand together as one community and send out the most positive vibes to everybody out there tonight who needs to know that they're not in this alone. We're all in this process together. And whether it's about the fertility thing, whether it's about work or relationships, about spouse or girlfriend, boyfriend, whether it's about school, no matter what the situation is that's getting you down, know that you are not in this alone, that there is always someone there who is willing to be that shoulder, and that there is always hope for tomorrow. As I like to say at the close of my program here, tomorrow is a new day and it is full of all new adventures. And I say that with all the sincerity, because just when you think that you weren't going to get what you were hoping for, sometimes it really surprises you. Life has a way of kicking us all in the butt. But you know what? Let's break the internet with kindness tonight, sending out all those positive vibes to people who need to know that they're not alone and that tomorrow is indeed a new day. And that's what this is about here, friends. It's about changing the universe one person at a time. Do some random act of kindness tomorrow. Would you smile at a stranger? Just do something nice for somebody, and you really will have changed the world in a very positive way. And that is the 5:30 Fuzzies with Fink. Thank you for being a part of that. Throw a heart on there if you would, if you liked it. Ask your friends to join in a couple minutes before 1/2 next week, because the more people we have to be able to share that good vibe, I think the more we can really change this ship that we live on. And that's my 2 cents worth there. Thank you for the hearts. I appreciate that. Let's see. Asking again about the tilted uterus during an FET. Is it harder to get it in the catheter, to get the catheter in the correct place for the embryo to stick? Well, not necessarily. No. The difference is that when the uterus sits backwards, it is sometimes harder for us to see by ultrasound. So when we do an embryo transfer, we're really trying to place the tip of that embryo catheter about 1.5 centimeters to 2 centimeters below the fundus, which is the tip, the top part of the uterine cavity. And so seeing with the ultrasound is a very important part of the embryo transfer. And that's why we ask you to have your bladder full, because when the bladder's full, it flattens out the uterus. It makes it easier for us to see, because when the ultrasound is going through the bladder, it gets rid of some of the shadowing and stuff that might otherwise make it hard for us to visualize. When the uterus sits backwards, it sometimes is harder to see, Nessa. And so in that scenario, it's not that the catheter is harder to get into place, but sometimes it's just harder to see where the tip is and where the embryo goes. Now, that's something that we're trained to do, so we know how to do that. But when it's a nice mid-position uterus, or a nice uterus that sits forward and you can see that little flash of light very clearly, then you say, oh, yes, of course, everything went great here. When you as the patient don't see that, then you may not have as much confidence. But again, that is what we're trained to do, to get that embryo into the right place. Now, some people have an issue with their cervix, that the cervix, instead of being a nice little straight tunnel that leads in, may have some little curves in it. It may curve to one side or another, like something like that, or maybe it curves and it actually kind of goes up here like that. And so sometimes it takes a little longer for us to be able to negotiate that little curve. That's something that we're looking for when we're placing the embryo catheter. But the mere fact that the uterus sits forward or backward, tilted one way or the other, should not change things about the way you get pregnant. So fingers crossed there, my friend. Fingers crossed. Let's see what else we have going on here. E. Romero says, Dr. Fink, our little guy Emilio that you did the transfer for, oh, fabulous, just turned 2. Thank you for giving us our miracle. I am so happy to hear that. That is the most wonderful news that I can hear. You don't know how much that really absolutely makes my day. Thank you so much for sharing that. And congratulations on Emilio. And I'm sure that everybody's asking you, when does Emilio get a sibling? And let's see what else here. M. Rich is here in Wonderland. Hello, and M. Rich said, you killed it with my tilted uterus. My bladder wasn't full, and you had to go by feel and experience. My daughter is 2.5 years old now. Biggest blessing after 12 years of trying. God, you know what? I really appreciate you saying that. That's really kind of you to share. I appreciate it, and I just can't tell you how much. Thank you again for sharing. And gosh, I wish some of you guys would send me your baby pictures because I'd sure like to see them. I was your first babysitter, so I think send me a picture. Why don't you? Instagram is a good place. Randy Fink MD. I'd appreciate that. Let's see. Salsa is here. Salsa 2014. Hi, Marlena. And Marlena asked, during a medicated FET cycle, should you take L-arginine while taking estrogen, and how long do you take it for? Okay, so L-arginine is an amino acid that is part of the evidence-based protocol for embryo transfer. And really what L-arginine does is that it's a vasodilator. It dilates blood vessels, so it increases blood flow that's going to the uterus, that's going to the uterine lining. So in theory, it's helping your uterine lining to grow nice and thick and warm and juicy and beautiful and perfect for your embryo. So yes, I do think it is an important thing. It's 6 grams. It's actually it's a lot of L-arginine that you take. The number is higher than you would think. You'd say, gosh, that's a lot, but that's just what's kind of in the capsules there. I do recommend taking it as a capsule because it's easier to swallow. I've seen some L-arginine that you can, like inositol, that you can mix with in a liquid, and then you have to kind of choke it down. I would absolutely take it as a capsule, but yeah, the pills are big. But yes, you take it with your estrogen. It's increasing blood flow. How long do you take it? I say that you stop L-arginine when you have a positive pregnancy test. Now, there is no harm. It's not going to harm you to stay on it. You just don't need it anymore. Your body already has some in there. And so what you want to do is, I say stay on it until you have your positive pregnancy test. And that's kind of the way I would do that. And I'm sorry, Krista, I forgot to answer your question there. Is Omnitrope a good medication to prime with? So Omnitrope is human growth hormone. And here's the story with human growth hormone. We often grab it. Many clinics will go for growth hormone or Omnitrope when we are concerned about egg quality. And when I say egg quality, I'm talking about the stability of the DNA that's in your eggs. Omnitrope, and the thinking there is that, well, you know what, as we mature, our growth hormone levels start to decline. And if your growth hormone level is going down, then giving you some more growth hormone may just kind of help your body keep itself young, i.e. specifically as it pertains to your eggs, that it may improve your body's DNA repair mechanisms, which help to give us maybe better eggs. So the issue there is that there's just not very good evidence on it. The evidence, in fact, shows that using Omnitrope or growth hormone really doesn't affect pregnancy outcomes or for that matter, even the quality of eggs or embryos. Now, that said, most of us who have been doing this for long enough will tell you that we have seen people that did poorly, and then they got Omnitrope and suddenly, wow, they did great. So what that tells me is that we just don't know the exact population for whom it's beneficial. So therefore, we kind of use it for anybody we think who might need it. Does it help? The jury's out. It definitely, I think, helps some people, in my opinion. It's expensive. That's another thing. Now, the price of Omnitrope seems to have come down considerably. If you kind of walk into Walgreens and just try to give a prescription for Omnitrope, yeah, they'll get it for you. They don't keep it on the shelf. They'll get it, but it's like $5,000 for a vial. I think it's $300 to $400 now from most of the fertility pharmacies, the discount fertility pharmacies. So that's a good thing. I do recommend it. Sirolimus or rapamycin is another thing that we can also use that may help us with egg quality, and it's considerably cheaper. But Krista, I would say that yes, I do use Omnitrope. Typically, I start at, there's a couple of different protocols, but for most people, it's 21 days before stems start. And I usually do it every day, and then I stop it at the time of your trigger. There are other protocols where you can use it in the months leading up to IVF, and biologically that may make a little more sense because you're getting that growth hormone or the DNA repair to those eggs in the months before they're kind of being called upon to go to work. So, I do like it. Again, it has its uses, but if you're a strict believer in the letter of the law or what the evidence says, it is that Omnitrope really doesn't help, but I think it does. What about suppression? Omni for suppression before FET. I think you may mean Orilissa for suppression before FET. So Omnitrope or growth hormone is not something that we would use for suppression. Orilissa we use for suppression before FET in the face of endometriosis. And the evidence shows that it is really just as good as Lupron. And Lupron was the very first and really the only medication that we had for endometriosis for probably 30 years. And so it's very, very well studied. Orilissa definitely does the job as well. So I think maybe that's what you're asking about. Omnitrope would not be for suppression. I don't really feel like growth hormone has much of a role when it comes to embryo transfer. Much more important, really, I think, for egg retrieval. Is baby aspirin used for better blood flow in the lining of the uterus? And so, yes, that is for one of the things that it can be used for. So baby aspirin probably has a couple of different things. So it can thin the blood a little bit, which results in an improvement in the blood flow that's going to the uterus. So, yep, I think that's important. It also can be used for certain types of blood clotting type issues. In fact, if you're just sort of using it, let's say that your lining is thin, using some extra baby aspirin, you will see the result. You'll see that the lining does get thicker due to the blood flow. But it also seems to have some effect on some immune function. And so there are times that we have people on both a blood thinner, like if they need to be on Lovenox, which is an injectable blood thinner, and baby aspirin as well, because they have different pathways that may do different things in the immune system. But baby aspirin, the evidence shows us that baby aspirin is really probably not something that the general population needs as it pertains to thickening the lining, and that is, kind of what it's used for. But some programs will use it routinely, but the evidence shows us that in the general population, it's not something, strictly speaking, that's necessary. Is there any harm to it? Probably not. Will it help? It may just. And certainly, if you've got an issue that where that lining isn't getting thick enough, then in that situation, yeah, I do think it probably makes some good sense. Let's see what else. Dee asked, any of the clinics use mini IVF versus regular IVF? So what does that even mean? What is mini IVF? So people use that terminology, but I have to tell you, it can mean different things to different people. It just means using low doses of medication. And where we are now with understanding is that our thinking used to be that, well, if you have a diminished ovarian reserve, that you need to use very high doses of medication in order to get your ovaries to respond. But what we know now is that there just isn't a linear increase in the response, which is to say that using more medicine doesn't give you necessarily more eggs. There's a threshold after which using more really probably doesn't help. Most of that data says using more than about 300 units of FSH probably doesn't make a whole lot of difference. So now mini IVF is classically using a much lower dose of hormone. And you can definitely do that. We always typically do that with PCOS patients because their ovaries typically are at risk for hyper-responding and making too many eggs. But if you're talking about mini IVF in a normal responder, then what you're saying is that you don't want to get the most, you don't want to maximize your number of eggs. So I don't typically recommend this so-called mini IVF for those who are considered to be normal responders, because really what we're doing is we're playing a math game with IVF, and that is to try to maximize the number of eggs that we get, to maximize the number of embryos that we get in order to maximize the number of options that you have and maybe babies that you're able to have. So any clinic can do mini IVF. It's just worth a conversation if you are choosing to do a lower dose protocol. Now, again, with significantly diminished ovarian reserve, mini IVF is sometimes the first thing that that folks will go for. But you know, it's worth a conversation with your doctor about what both you and they feel like is going to be the best dose for you. Hopefully that answers the question there. Let's see here. Bren is here this evening as well. Hey, Bren, nice to see you. I am transferring again 9 months after a C-section. Do I need a saline sonogram and an HSG, or just a saline sonogram? You do not need an HSG. So the HSG is a hysterosalpingogram, and that is what they also call the dye test. The dye test is really designed to look and see, are your fallopian tubes open? Well, fallopian tubes open, that's a requirement in order for a sperm to swim in and meet up with an egg that's getting released from your ovaries. So that's really a part of a basic fertility evaluation. I do not feel it has any role when it comes to doing an embryo transfer, because your tubes don't matter unless you have a hydrosalpinx, which means one of your fallopian tubes is full of fluid, but generally, if it is a significant enough filling of fluid, or a hydrosalpinx, to be clinically significant, then that's something that should be seen by ultrasound. HSG is not the test of choice for identifying a hydrosalpinx or fluid that's in the tube. So some people will order the HSG routinely. There are places I have seen where sometimes the clinicians will just routinely order the HSG without really understanding what it's looking for or what the evidence shows. If you have delivered, you're talking about just doing another transfer, a saline sono, sure, you want to know that that uterine cavity doesn't have any scar tissue and that it's just perfect and waiting for your next embryo. But HSG, no way, I wouldn't do it. Now, that's just my opinion, but that's grounded in the evidence. And if somebody told you you need an HSG, I would suggest they may not be fully acquainted with the evidence there. And I did your retrieval. Yay, I love it. I love it. I love it. I am so happy to hear that. And Kelly says, so you don't start L-arginine until you start estrogen? Well, I like to see people, so the medications that you need, or rather the supplements that you need for embryo transfer, your prenatal vitamin, vitamin D, vitamin E, CoQ10, I like fish oil or omega-3, and L-arginine. You really technically don't have to start those until your transfer cycle, but if you want to be on them for, let's say, the month beforehand, I think that makes sense. Although It is factual that your prenatal vitamin, you're supposed to be on for 3 months before conceiving, because that prenatal, it's that folic acid that prevents certain types of spinal birth defects 3 months before having the baby. So yeah, I would say that I think you're fine to start it, that supplement when you start your meds for that transfer cycle. A special good evening to Dr. Puchek. Thank you so much for being here, and welcome to Pensacola. And Pui, my friend, is here from the sushi station in St. Louis, and I almost came to the restaurant. I am coming there next time. 100% guaranteed. I must be there. Best sushi in all of St. Louis. Honest to God. Brienne asks, DOR here. Max doses did absolutely nothing for me. 0 blast. I tried mini and I did okay, but I moved to a medium kind of standard dose and had the best outcome. And it is unfortunately some trial and error there. But the reason that maybe those super high doses didn't work so well were because your ovaries are not used to getting that much stimulation. You get that much stimulation, the ovaries are like, what am I supposed to do with all this? And they kind of go, nah, and then they stop, and they just may not give you anything. So then you went to a lower dose and you got some response, but it sounds like, a little bit more, pushing a little bit more was sort of your happy medium, your sweet spot there. And I'm so glad that that's the one that did the trick for you. But yeah, I tend to avoid those really very high doses, especially in the DOR patients, DOR, diminished ovarian reserve, because I just don't think that they work. And sometimes you do much worse. Sometimes they can hurt more than they help. Let's see. Hey, Zamanira. Oh gosh, I have the hardest time to say that. Will Omnitrope help with a low AMH? So, we were just talking about Omnitrope here. So that AMH level, when it is below that 0.08, is what we call the undetectable level of AMH. And it's a tough spot to be in, because that's suggesting that really your ovaries are not going to respond well to the medication that we use to stimulate you. In that scenario, sometimes we want to know what's your FSH hormone look like? The Omnitrope is not going to give you more eggs. The folks who use Omnitrope are doing it because our hope is that it improves your ability to correct some of the age-damaged DNA in the eggs that you have. The AMH is generally more a reflection of how many eggs are there hanging out, waiting for your brain to say, come to work for me here, and rising to the surface of the ovaries so that they can go do their thing. I wouldn't say that Omnitrope is necessarily the best choice there. It might be something that's used in combination with some other tools that we might have to see if we can do anything about your ovarian reserve. And that's really a very experimental thing right now, but a tough situation to be in there for sure. Sharmila is here, and I'm happy to see you and your baby here, Sharmila, after all that we went through. So thank you. It's very nice to see you. Folks, we're going to be about out of time here tonight. I'm so flattered that you were able to join me, and I really do appreciate it. As always, every Tuesday evening at 5 o'clock Central Time, which means 6 on the East Coast, 4 in the West. That's the place for Fertility with Fink and Friends. I am Fink. You are Friends. And, every step forward with love, every step forward with kindness. We talked about that with the fuzzies with Fink. Do something nice for a stranger tomorrow, would you? And every step forward with hope, because tomorrow is a new day and it's full of all new adventures. This fertility thing is not the book of your life. It's just a chapter. And what are we doing? We're writing the damn thing again. We're rewriting it, and we're doing it together. So until next week, Dr. Randy Fink in Pensacola saying thanks so much.